Hello and welcome to the DSERA Infectious Disease Podcast, formerly the Clinical Care Options Infectious Disease Podcast. In today's episode, we feature a recap of our roundtable discussion on RSV and diagnostic testing. To follow along with the slides, see the link in the show notes. Now let's get started.
Thank you so much, everyone, for joining us on this roundtable discussion, RSV Revealed, the role of diagnostic testing in advancing clinical care. And I'm so pleased to introduce my co-faculty on this presentation. First, we have Dr. Tracey Davidoff, who's an attending physician at Baycare Urgent Care. She's an assistant professor in family medicine at Florida State University College of Medicine in Tallahassee, Florida. We also have Dr. Jeffrey Whitman, who's a co-director of clinical microbiology. He's an associate professor in the Department of Laboratory Medicine at the University of California, San Francisco, California. And then I'll introduce myself, Dr. Carina Marquez. I'm an associate professor of medicine in the Division of HIV, Infectious Disease, and Global Medicine at University of California, San Francisco. So to get us started in this discussion, I think it's really important to start us off with RSV burden. And this will really help us understand the why and the when of testing. So here we are with the RSV burden. These are data from the CDC that really encapsulate the burden of RSV in 2024 to 2025. RSV accounted for 3.6 to 6.5 million outpatient visits a year. So this is really a massive burden of medically attended visits. The disease can be quite severe. So in terms of hospitalizations, 190,000 to 350,000 hospitalizations due to RSV. And then mortality is high, 10,000 to 23,000 deaths last year due to RSV. So this really sort of highlights the magnitude of this infection. And it probably is an underestimate since we aren't testing as much for RSV. So probably an underestimate of the true burden. I think when we talk about burden of RSV, we really, I think, all know very well the burden in infants and young children. And again, data from the CDC highlights that this is the leading cause of hospitalization in infants, and estimated to cause 58 to 80,000 yearly hospitalizations in children under 5. And I think, many of us can never forget caring for patients who have bronchiolitis and young children, or even as parents, we probably will never forget that. So really high burden that I think is quite well known. Well, I think what's less well known, but I think is really starting to understand, and I think this is getting out there a lot more, is really the burden of RSV in older adults. And I think this is coming up a lot more and a lot more education around this, especially since we have the RSV vaccination now in our toolkit for older adults. So let me just share a little bit about RSV in older adults. Again, the burden of outpatient visits quite high. So 1.4 million visits per year. Hospitalizations, 160,000 per year. And deaths, 6,000 to 10,000 per year. And this disease burden is expected to increase as our population ages. And it's also important to recognize that the burden of morbidity and mortality really increases with age. And so 80% of those deaths there occurred in patients over the age of 65. A lot of people ask, how often are people exposed? How often are older adults in the community exposed to RSV? And it's much more common than we think. So here you can see the RSV attack rate in older adults, and estimates in the community setting range from 2 to 10%. So this can be quite high just for your average older adult. And then this increases in congregate settings with ranges of 5 to 10% in attack rates. And that's sort of compounded with increased frailty and other comorbidities. So again, really important to think about RSV in older adults. And, we've been definitely thinking about it more so, I think, in the last few years. So really important. Okay. Again, also trying to think about, well, how much RSV, if I'm in the urgent care setting or primary care setting, how much would I be seeing if I was testing? And so these are two studies. The first one's a community cohort study looking at adults over the age of 60 who were seeking outpatient care for acute respiratory illness during the winter seasons. And so in the winter seasons, within this cohort, RSV was identified in 11% of 2,257 medically attended respiratory illness cases. So quite high. And then the second study is a qualitative systematic literature review of 22 US studies looking at laboratory confirmed medically attended RSV visits in adults over 50, which highlighted that RSV similar numbers accounted for 12% of medically attended acute respiratory illness cases. And this isn't among older adults without comorbidities, and certainly the percent increases as the proportions when you're looking at hospitalized cohort or older cohorts. So again, high proportion if you're testing and in during that respiratory season. So I've talked a little bit about the burden, and I'm going to turn to Dr. Davidoff to give some perspective in the urgent care setting. So tell me, do you feel that providers in urgent care settings adequately consider RSV as a potential cause of respiratory illness in otherwise healthy patients? Or is this largely under-recognized outside of high-risk groups? And sort of any insights into how this changes in adults versus children?
I think absolutely this is under-recognized. A lot of the reason for that is because we really haven't had great testing for it, and it's really not as widely or has not been as widely available in centers, urgent care centers, as I think it will be in the future. And also because, as we said, it's really a disease more of the more serious cause of disease in the young and the old. So, and in the majority of patients that we see in urgent care are somewhere in the middle. So I don't think we really need to identify in those patients. We'll talk about that a little bit more. But I think certainly in adults, it's now coming to light how much more important it is to make that diagnosis in adults. And I think this will be something up and coming that we're going to hear a lot more about and that we're going to see a lot more in the future. Also the technology has improved. A lot of the RSV antigen testing that we saw was really only approved for those younger people. So we didn't really have an option to deal with diagnosing or testing patients in those older age groups. So I think this is something, yes, it's completely underrecognized and unappreciated, as well as underappreciating the severity of things. And as more studies come to light and the technology and the testing capabilities become more available, I think we're going to be talking about this and recognizing this a lot more than we have previously.
Absolutely. I completely agree. And I think it's one of those things, even when I do a lot of HIV primary care in the clinic when I'm talking about vaccination, a lot of patients are like, I don't, even older adults didn't know that they were even at risk. And so I think this awareness is really increasing, and then we're starting to see more testing. So thank you for those insights.
Right. Okay, so we're going to talk about the difficulties with RSV diagnosis in the absence of testing, because as I've said, testing has not been widely available in the urgent care setting and really has only been thought about for younger people. So, as we know, the symptoms of the common cold, influenza, COVID-19, and RSV, there's a lot of overlap between these. So, most people with these illnesses will have some aching, will have some difficulty breathing. Everybody has some fatigue. Fever is also a widely common symptom in people with these respiratory diseases. Loss of taste of smell, that was really popular with the earlier versions of COVID, less so now. I mean, although it can occur with any respiratory virus, it's not a particularly common thing, but it's not something that we can specifically say is owned by any of one of these viruses. Sore throat, again, a very common symptom that appears in all of these respiratory viruses. And wheezing, although less common in cold, flu, and COVID-19, it can occur, more common in RSV. But the point is that you can't pick one or even a couple of these symptoms and say, oh yeah, this is definitely RSV or this is definitely COVID-19 based on the symptoms. So history and symptomatology, not terribly helpful in trying to distinguish one illness from the other. Seasonality, again, sometimes that's a little helpful with trying to tease out which one of these infections is causing your illness in the patient that you're looking at right then and there. There are seasonal outbreaks, especially with RSV. There are two subtypes, subtype A and B, where we see most of these will onset somewhere in mid-September to mid-November, usually peaks in December to mid-February, and then usually is gone by the onset of mid to late spring. So there is definitely a season to this. I don't know, will this stay like this forever? As we've seen post-COVID, that's been sort of changing a little bit with influenza, might be changing with RSV as well. But again, you can see the large gap between onset and offset of this infection. Usually if you're right in the middle of winter, that is the heart of RSV season, but you certainly can't 100% use this to diagnose, oh, this must be our RSV because it's occurring in December. So, Dr. Marquez, with overlapping symptoms among RSV, influenza, COVID-19, and these other respiratory viruses, non-specific, or even if we're testing specific viruses, what are the risks of relying on that clinical presentation alone?
Thanks. This is such a great question. I think there's so many overlapping symptoms between COVID, flu, and RSV. And during those winter seasons, when they're all circulating, it's very difficult and to tell it apart just based on clinical presentation alone. So during the winter respiratory virus season, you got to think about all three of those and run those tests. I think there are certainly during the summer or outside of respiratory virus season where you can rely more on symptoms and where you're thinking, where when the flu season is over or RSV season is over, if you're in the summer months, then, it's those are unlikely and you're thinking more COVID or other respiratory viruses. So I think using the seasons to guide you in terms of when you're testing, I think is very helpful. But the symptoms alone, especially during those respiratory seasons, is just not enough.
I think a lot of the importance of that too is, you have to know what's in your community. You know, you have to get that information, or even if you just, put it in your head from the people that you've been seeing. I mean, if there's no influenza in your community, the chances of that patient having influenza are much smaller than if, the last 10 patients you saw had influenza. So, I think you kind of have to use common sense with that as well.
Yeah, absolutely. And I know when thinking about testing, I definitely rely on the reports coming out from our hospital system to inform, what is the local epidemiology? Are we starting to see some flu cases? Are we seeing, when are we starting to see these RSV cases and when does it tail off? And that definitely, I think, impacts how I'm thinking about testing. Same thing with COVID. And so we're using some of that epi and then our general knowledge of seasonality to help guide those, but a lot of overlapping symptoms. So along those lines, I work mostly in the primary care setting or in the hospital setting. But Dr. Davidoff, how might the use of symptoms or testing be different in urgent care settings, especially where rapid decisions are needed? Your patients come in, they want to go home quickly. How do you think about testing in those settings and the use of symptoms?
Well, I think, in urgent care, we're really good jack of all trades. You kind of have to be able to use every bit of information that's in your toolbox. So you want to make sure that, you're getting a good history from the patient. You're asking them about potential exposures. Are they in daycare? Do they have a child that's sick? Have they been exposed to anything specific? And then also use those symptoms to kind of help, as well as that information about what's circulating in the community, be it just general information that you've pooled yourself or from your coworkers, or if you work in a hospital system or you have access to data from a hospital system or from your local health department of what the percentages of positivities are in your tests. Where I work once a week, we get a list of, what the positivity rate is for influenza A, influenza B, RSV, as well as COVID-19. So that kind of helps guide us about what is prevalent in the community currently, which, putting all of those pieces together and then adding that to your testing capabilities, will give you that likelihood of what disease you think that patient may have and how important that is. So, it's not just a test, it's knowing what your pretest probability is, what your prevalence in the community is, and as we'll talk about later, what your sensitivity and specificities are of your test as well. So it's not just an all or none easy way to make the diagnosis, and you got to get good at this. You got to get good at appreciating, all of these factors together and making those rapid decisions when you're trying to see 4 or 5 patients an hour.
Thanks so much. So I think as we're thinking about testing, it's important to think about potential benefits of RSV diagnosis and why we would test. And especially, I think this is a really important question in the setting of there not being a treatment for RSV. So really, why tests? And here are some thoughts about why a diagnosis is important when we're thinking about respiratory viruses. First, there are many respiratory viruses that have no treatment, RSV being one at the moment. We hope for treatment soon. And in many cases, making a specific diagnosis is not important. I think this depends on the virus, depends on the patient, but we see a lot of acute respiratory viruses, and diagnosing rhinovirus or parainfluenza in the outpatient urgent care setting isn't really critical because the care is supportive. We can provide that guidance without the diagnostics in that setting. However, there are, as we know, certain viruses that do have treatments and antiviral treatments, and it for specific populations to prevent and decrease the risk of severe disease. So, for example, of course, COVID and flu have antiviral treatments. RSV does not have an antiviral, as I mentioned, though in some subpopulations, for example, severely immunocompromised patients, like transplant patients who are admitted to the hospital who have lower respiratory tract infections, there we do use some therapeutics, oftentimes like ribavirin or IVIG, but that's specific cases. But in general, RSV does not have a treatment. So, however, knowing that a patient has RSV or their specific virus can help guide patient education, prognosis, and thinking about treatment. How do we think about clinical impact of RSV and viral testing? Well, first, I think of it broadly. It can help guide global care for your patients. So, how so? Well, I think in four ways. The first two are patient level specific benefits. They can affect patient management. For example, it can help avoid treatment that may not be beneficial, for example, antibiotics, or can help you, if it's another virus like COVID or flu, can help you prescribe antivirals if they're indicated. Another benefit is patient education and counseling about the specific virus. And then secondly, there's also really important to think about public health benefits. So one benefit being infection control, and this can have broad implications. So in the hospital or clinical setting can help guide isolation requirements, or if a patient is in a skilled nursing facility, can guide infection control when they return to that skilled nursing facility. Also can help give guidance in the case of pediatrics about when someone can return to school. And then the fourth benefit is public health and surveillance in general. So Dr. Davidoff really mentioned how knowing when RSV or other respiratory viruses are peaking in the community or when they're starting to be detected helps inform decisions to make to order tests. This I think is another benefit. So it informs test ordering and public health actions. So the other thing I want to mention, and of course, as an infectious disease doctor, I love to always talk about antibiotic prescribing practices and stewardship. And I think this can be an important tool for decision making. And I wanted to just highlight this great study looking at patients presenting to large health system in the Midwest. And they looked at people who came with upper respiratory tract infections, most of which do not necessitate antibiotics, or antibiotics are unnecessary, for example, in bronchitis, pharyngitis without a positive test, acute rhinosinusitis without an indication. So they looked at these, and also nonspecific upper respiratory infections. So they looked at each of these diagnoses and asked how many received unnecessary antibiotics. And you can see that 20,000 in these over 49,000 patient encounters, 20,000 people received unnecessary antibiotic prescription rate of 42.2%. So I think it's a good reminder for all of us in the outpatient urgent care setting to really ensure that we're prescribing antibiotics with the right indications. And this can be tough sometimes. People come in, they want antibiotics, and having a diagnosis, for example, a viral diagnosis, can also help in that explanation process and also help you as in your toolkit about deciding whether to use antibiotics. So I thought this was a really nice study illustrating that topic. Okay, so to Dr. Davidoff and Dr. Whitman, how does confirming RSV infection impact patient care at the individual level and at the public health level? What does this look like in your world, in your practice?
Well, I think as far as, extremes of age, the very young and the very old, absolutely makes a difference because you can predict, which patients are at a potential for decompensating, for needing more care. You can warn them a little more firmly about, if you get worse, you're going to need to seek care. This is a possibility. You have RSV. With patients in the middles of age, so, children over 5 and those under the age of 65, it doesn't really matter. And those people, it's just a cold. So for them, as far as predicting, how sick they're going to get, not terribly helpful for that. But the beauty of it for letting them know is in the public health spectrum. One, if they have an infant at home, if they had taken care of the elderly grandmother, or they're taking care of any of those people that are higher risk, which we'll talk about in a little bit, it might be useful for them to know if they have RSV so that they can take those extra precautions to prevent those at-risk people from getting sick. Very similar to COVID. We mentioned that with COVID-19, the same thing, stay away from those patients that are higher risk, make sure you mask and keep isolated away from them. Also, as far as we talked about for surveillance purposes, knowing, which people have COVID, the degree of COVID, gives you those numbers and that data to help other patients that are at higher risk. So, from an urgent care perspective, that would be why we would want to know if people have RSV.
From my perspective as a pathologist, I don't really do direct patient-facing care, but Carina, in our work together, we often are in conversation about these things and what the impact is on individual patients. So working in a hospital setting, providing fast and accurate diagnosis for this allows you for infection control. If you have a patient who's going to be admitted, you want to know if they have an infection that could be communicable in those hospital settings. So we want to be able to provide that level of detail. And then also for people who may be in the household, you want to know, just because you're testing that one patient who's presenting sick, there might be other people that are at risk. So that could be major implications for impacting it at the individual level. At the public health level, we're testing the whole hospital. So in the clinical laboratory. So that data that we have, we want to aggregate it. We want to provide those results either at our individual epidemiology within the hospital, letting other providers from the hospital know what's happening in their patient population. And then depending on the public health system, whether those results get reported to the public health system so they can aggregate them with all other hospitals who are presenting that data and getting a broad picture of your region, either at the city, county, or state plus level.
This is great. And I love, just to chime in from the primary care perspective, I completely agree with what Dr. Davidoff was saying about sort of the impact on counseling is, when you're testing when I send a respiratory viral panel and if it comes back for RSV in one of my older patients who may just have a URI and he's overall doing okay, it allows for really tangible discussion about return. Of course, we always give return precautions, but it gives sort of much more specific about return precautions, and I think really helps the patient know what they should look out for. And so that diagnosis does help a lot with counseling too. So really helpful. And then again, even when patients are coming in from the ED or urgent care to the hospital setting, agree with Dr. Whitman, knowing these diagnoses up front really helps before, instead of doing the test later and then discovering there's been exposure. So the infection control piece is also extremely important. Great.
Okay, so switching over to who do we decide to test? What is our patient selection criteria for testing people? And I think, with some of the previous discussions we've had, we kind of have a clue of how this is going to work, but let's go over it. So making the diagnosis of RSV is actually twofold. You're not doing it in a vacuum. It's both clinical suspicion and positive test or a high probability of disease. So we're using these two items to kind of decide who's at high likelihood of having RSV to decide who to test, because we don't just want to test everybody that walks in the door for RSV. That's neither cost or time effective. So we want to have some pre-test probability here to decide who we're going to test. So when to suspect RSV, like I said, in the middle of summer with no circulating virus, probably not going to suspect RSV in those people. So you want it to be winter season with known RSV circulating in the community and someone who has symptoms that are consistent with RSV. So it's a younger child with bronchiolitis who has compatible clinical and epidemiologic features. Their age is less than 24 months. Can older kids have bronchiolitis and have RSV? Absolutely. But the ones we're really going to worry about are the ones age less than 24 months who have some degree of respiratory distress with wheezing. Those people are going to be much more likely to have RSV than the ones who do not have those clinical features. And then also older children and adults who might be hospitalized with a lower respiratory tract infection, especially those at risk. So those that are immunocompromised those who now have pneumonia and clearly have some severe disease going on, bronchitis, and those who are having an asthma exacerbation or COPD. Important to know what infection, if any, might be contributing to that asthma exacerbation or COPD. And then any patient who has respiratory symptoms and known exposure. So that mom that has a kid that has illness that's already tested for RSV, or grandma who has a grandchild who's got RSV, or maybe a healthcare worker or someone who's in a position where they have a known exposure to RSV. So we want to avoid routine testing. I call it the spray and pray. In urgent care, we want all of our tests done right away, usually on a standing order by the nurse or the medical assistant, because we want to know what that patient has before we walk in the door to save us some time. I call it the trifecta. The person comes in with upper respiratory symptoms and they're automatically tested for strep, flu, and COVID during those seasons. So do we want to add RSV to all of those people and have what would it be called, a quadrifecta at that point? Not everyone needs testing for RSV. We don't really need to do that. And really, a rule of thumb for all testing, in my opinion, is will the result of that test change my management of the patient? And if that answer is no, you probably don't need to do the test and it shouldn't be performed. So if you have, somebody in their 40s with a cold who's at low risk, has no infants at home, is not a healthcare worker, it does not have any comorbid conditions, we really don't need to think about doing that RSV test, because it's not going to change our management, because there is no treatment for it and there is no public health implications of that. So routine testing should be avoided for RSV in most outpatient, in non-severe and mild cases, because the treatment is primarily supportive and it will not alter your management. And this thought is supported by both the Infectious Disease Society of America in their clinical guidelines, as well as the American Academy of Pediatrics. And there are references available for that within this program. Dr. Marquez and Dr. Whitman, if the results aren't going to change your patient management, when should we test people for RSV?
So I can talk about that a little bit from a laboratory perspective as well. So oftentimes you may be limited by what test menu is available in your laboratory. What if your laboratory only has tests for RSV in combination with other tests, and you may not have the option to click it on and off? So you may have to say to yourself, how do I manage this if I have limited options for testing, or maybe not options to opt out for it? So that may be one thing, is that if your laboratory provides it, you may offer it just because it's there. And that's a discussion you should have about cost benefit and utilization with your laboratory director. But ultimately, those may be decisions at a systems-based level and not at the individual provider level. So that is one component to think about this in.
I think one reason to test, if it won't change management, for example, of this healthy 40-year-old, could be infection control reasons and public health specific reasons. For example, if that person lives with a highly vulnerable older adult who's immunosuppressed, this may impact sort of actions within the household, or they may avoid that person. So there may be some public health specific reasons that could impact treatment. And then there are some also larger surveillance studies. But overall, I think most of the time we're focusing on testing to impact patient management, but also taking into account, in some cases, public health and infection control reasons.
So I think one of the important points here is you got to ask the questions, right? So, going back to our 40-something, with no comorbid conditions who just have a cold, you got to ask, do you have a newborn at home? Are you taking care of that elderly family member? Are you a healthcare worker? So, I think that we really need to ask those questions and tease out, which of those patients should we identify as needing testing, assuming we're not going to be, blanket testing everyone. So that's definitely an important point to that. Okay, so when can you make a clinical diagnosis without testing? Well, as we said, you can make that diagnosis if there's RSV in the community, so that there's a risk of potential exposure, or if the patient has a known exposure, say they have a child that has RSV, or their elderly parent is admitted to the hospital with RSV. The patient has known symptoms of RSV. Again, remember, these are sort of non-specific. But, in a child, if they have symptoms of bronchiolitis, that makes it a little more likely, especially during RSV season. And the patient has no risk factors for severe disease. So, having all of these things, we can make that diagnosis clinically. You don't need to do a test. And these patients can be diagnosed with RSV without the test. Again, if the result will not change management of the patient, or again, if we're not looking at any of those public health concerns. So, I think the majority of the patients that we're going to see in urgent care, if you don't see a whole lot of pediatrics, or if you're not a pediatric urgent care, a fair amount of patients that you see won't necessarily require RSV testing. There may be, like I said, there may be other reasons to do it that may be public health concerns. So, who are those patients that are high risk? We talked about the elderly and we talked about the very young, but there's actually, we talked about immunosuppressed, but there's actually more people that are at risk for those things. So, anyone who's premature, so before 35 weeks of gestation, infants who were born before 35 weeks of gestation, age less than 6 months. So, those are the people, the children, the infants that get very, very sick, especially if they're born during the first half of RSV season. So, which kind of makes sense if you do the math. If you're 6 months, then you were probably born just in the first half. So if you're born in the second half of RSV season, the amounts are waning. So those are the ones that you got to worry about the most. Daycare, remember, anybody who's ever sent a child to daycare knows that these illnesses fly around like wildfire. Your poor child is always sick if they're in daycare. Older siblings of those children that may have RSV, children aged less than 5 who may have some social vulnerabilities, so those in the lower socioeconomic classes or those that are in third world countries, children with congenital heart disease, HIV-exposed infants, residents at altitudes greater than 2,500 meters. So, I'm thinking Colorado here. Secondhand smoke exposure. So parents who smoke, their children are at higher risk for getting severe disease from RSV. Children with Down syndrome because of all of their comorbidities. Those are immunocompromised for any cause. And don't forget to think about, with all the monoclonal antibodies and those disease modifying drugs that we now have floating around, a lot of those patients are also considered immunocompromised. And remember, a lot of the patients won't think that infusions are medications, and they won't tell you about that. So you sort of have to tease out, does this person have Crohn's or rheumatoid arthritis? They may not have any medications on their list, but when you ask them, do you go get an infusion once a month? They're like, oh yeah, because they don't think of that as a medication because it's not a pill that they take every day. So you need to make sure that you ask them about that. Persistent asthma, patients with chronic persistent asthma are at higher risk of developing severe disease from RSV. Adults with cardiopulmonary disease, so those patients that have a history of CHF or some other underlying cardio disease, need to think about a more severe disease, some severe infection for them if they get RSV. And lung disease from any cause. So asthma, COPD, but also things that we don't see very often, like pulmonary fibrosis or cystic fibrosis, that sort of thing. Those are also at severe risk from getting an RSV infection. Dr. Marquez, in your clinical practice, who do you consider a must test for RSV?
Yeah, great question. And I see adults only. So for the must test is really the people who fit the criteria that you outlined, who are really at risk for severe outcomes from RSV. So older adults, people with frailty, immunosuppressed, and also I'll add patients who are living in congregate settings. That's how I really think about it. And the other thing to also think about is hospitalized adults during the respiratory virus season, the winter season, who are coming in for pneumonia or upper respiratory infections. That group I'm also always want to see respiratory virus testing as well. So those are the people that I really think about.
Okay. And Dr. Whitman, if you could address this, what are the pros and cons of testing otherwise healthy adults who might have a mild respiratory illness?
That's a good question. The pros, one of the biggest pros is that you do provide a diagnostic answer. If, let's say, you tested for very limited things like COVID or flu, and it's all these other respiratory pathogens, providing some answer does tie everything together and provide more patient assurance that the patient's being managed correctly. Also, just from the sense of getting if you do have testing options that are available to larger populations, especially healthy adults, you're going to understand the disease burden in the community. And so this goes back into the public health aspects of it, that you're going to say, oh, yes, this really is circulating in a lot more people than we're thinking about. And you can think about it in a risk-based scenario, like what's the risk in the community at this time? So you're contributing to public health and epidemiological efforts for tracking the disease. The cons of testing, however, are that these tests cost money, and they cost money for the healthcare system, for the patient. And we have to be cognizant of these as well. We want to be doing the best for our patients in terms of providing the best care, but also making sure that it is justified in doing good diagnostic stewardship. We really want to ensure that we are testing healthy adults, that it is justified in that population, so that we are providing the best overall stewardship from a cost benefit analysis standpoint.
Right. And, I should also mention here, we talked about earlier with the whole antibiotic stewardship thing, a lot of clinicians in urgent care, we're so happy when a test is positive because then we can say, oh, look, you have COVID, you don't need antibiotics. And that avoids that whole you don't need antibiotic discussion that we all dread so much. So, it might be helpful from that perspective too, to have an answer that, hey, it's a virus. But, one of the caveats to that is nothing says you can't have both. So many times I've seen people that are positive for both COVID and flu in the middle of season for both of those diseases. So, the same would apply for RSV. What says you can't have RSV and flu at the same time, or RSV and COVID, or even RSV and a bacterial infection. So just because you have one doesn't necessarily mean that you've ruled out the others. And I think we're going to talk about that a little bit with testing. If either of you could address what circumstances might testing be justified even if they're not high risk?
Yeah, I think that question really goes back to thinking about, even though they themselves may not be high risk, whether there is an infection control or public health benefit of the testing. So if they're living with a high risk person, that really could inform some of their knowing that they have RSV may inform, some distancing or mask wearing, or however they choose to try to decrease exposure to that high risk individual. So that knowledge sort of helps, that does inform behaviors. And then I think, again, congregate settings are really important because that allows you to isolate the person who may have RSV from people who are quite high risk. So really thinking about this in nursing homes, but other high risk congregate settings is important.
Yeah, absolutely.
From a laboratory standpoint, one rationale for testing, even when it may not be justified, is if you can justify it based on efficiency of testing, and you can actually maybe provide lower cost overall if you're only providing one test that is a multiplex of different pathogens than having to do it by each analyte, like, COVID on one, flu on one, RSV on one. That may provide inefficiency in the system that increases test costs overall, or, just inefficiencies in testing. So if you bundle them all together, it may be more effective overall.
It's funny that you mentioned that, because I had a patient yesterday that I really thought needed to rule out influenza and COVID, and the antigen tests were negative. So I was sending off a PCR to the lab, and I didn't have the choice to not add RSV. So, in that case, I had to do a multiplex test and adding the RSV. So justified, maybe not necessarily correct to do so, but, if I didn't have the choice, then I have to do the RSV test. So when we're talking multiplex testing, then yeah, that's something that's going to happen. All right. So these patients are the ones that should be tested for RSV in most cases. So infants or children less than 5 and adults greater than 65 who have moderate to severe respiratory symptoms, especially if they're hospitalized with a lower respiratory tract infection in the ICU or with mechanical ventilation. Of course, that doesn't really apply much to us in urgent care, but for your general knowledge. Patients with underlying comorbidities, remember we gave you that whole big long list, but more specifically prematurity, chronic lung or heart disease, and those that are immunocompromised. And remember, please don't forget to ask, because patients may not realize that they're actually immunocompromised because they don't disclose to you some of the medications that they're taking. Diagnostic clarification when multiple viruses are present. So the patient may be a candidate for antivirals if they have influenza or COVID, not necessarily for RSV, but it is definitely necessary to tease out, which disease is causing their illness, so that you can treat and cancel them appropriately. Again, we talked about, we're kind of beating this to death, but I always say, if you tell somebody in a lecture 3 times, that it'll stick. So For infection control in an ambulatory setting, you want to test people that have a high risk of suspicion. And then potentially, even if they're not at a high risk, if they're potentially exposing people are at high risk. So we talked about newborns at home, elderly at home, any long-term care facilities or daycare, healthcare workers. And that also testing the patient allows them to isolate from other high-risk patients. And then improved resource allocation. So if you're sending a person to the hospital, it will allow for some triage and admission decisions. If you've tested them and then you ultimately decide they need to go to the hospital, please let them know that that patient has tested positive for RSV so they can isolate them accordingly. It may also minimize the diagnostic workup. So if you know what they're positive for, you can test for less for other things and minimize unnecessary treatments. Again, we alluded to this earlier, they don't need antibiotics, steroids, or bronchodilators if they're an infant diagnosed with bronchiolitis, if you know that that bronchiolitis is being caused by RSV, because these treatments have not been proven to have any benefit in those patients. And then don't forget our public health surveillance and response. Who you test now may influence who you're going to test later. So it's good to know when that virus is circulating in the community. So it provides public health information for the future. All right, so I'm going to ask Dr. Whitman to talk about diagnostic techniques now.
Yes. So jumping right into it, the diagnostic techniques for testing for RSV are pretty much two modalities. You have nucleic acid amplification testing. There's a lot of ways that you can amplify and detect the nucleic acids of a virus. PCR is the most common, but it's not the only one. And you actually may be using other nucleic acid amplification techniques in your systems and not know it. So just to be more inclusive of the different types of testing, we generally refer to this as nucleic acid amplification, or NAT, versus PCR. And the methodology for PCR, or nucleic acid amplification, is that you take a swab. You will swab some part of the nasal mucosa or the lower respiratory tract, depending on what's being sampled. And you are testing for genetic elements of that virus. So if this virus is truly a pathogen, it shouldn't be there. And so if you are able to amplify parts of its genome, it proves it's there, and you will say, aha, this is the sort of gold standard detection method. It's highly sensitive and highly specific because it's testing those genetic elements directly. The other type of testing that you have is antigen testing, and this is testing the protein of the virus. So you will, again, take a swab in the nasopharynx, and from there you will usually put it on a more of a rapid style test, a lateral flow assay. Many people may be familiar with these from at-home COVID testing, but they exist for a lot of other pathogens as well, including RSV. So you'll take your swab and from your nasal or nasopharyngeal cavity, get those proteins in there and put them on the test, and they will actually have an antibody that captures those viral proteins and holds them there, and you detect it when the viral proteins are captured. And that shows up as a test line on these lateral flow assays. So we often talk about these in terms of antigen testing being more rapid point of care testing, where nucleic acid amplification testing be more of a laboratory test, even though these laboratory tests can be available outside of the clinical lab in some point of care settings, but they really are not sort of right there testing directly from the specimen as a rapid test. So the testing formats, as we've alluded to in other parts of the talk, there are different formats for testing for RSV. And the most common ones that are currently available, as Dr. Davidoff mentioned in her case example where she could only get that multiplex testing, oftentimes these are going to be incorporated into multiplex panels. So you're not just going to be testing for one virus, you're probably going to be testing for a few. You may have a large multiplex respiratory viral panel, which will usually include COVID, flu, RSV, coronaviruses, rhinoenterovirus, maybe a couple other pathogens as well that are non-viral, like Bordetella or Mycoplasma pneumoniae. But it just depends on the panel that gets sent out or what the laboratory is offering. These large multiplex panels are quite comprehensive. So if the patient's coming in is very sick and you really don't know what's going on, and it can be very severe, and you have to say, I really have to test a large number of things to help this patient in this acute presentation, these are often good options. The problem is that they come at a higher cost. You're testing more things, they're going to come at a high cost. And so there may be restrictions on reimbursement, especially in the outpatient or ambulatory settings. So oftentimes these are concentrated for inpatient settings where people are making a decision about whether they're going to admit someone to the hospital. More commonly, what we're seeing these days are these mini multiplex panels, including COVID-19, flu A and B, and RSV. These are also nucleic acid amplification panels, but they are usually in faster formats or quicker format, or they can have a turnaround time for a quicker format than the large multiplex panels, even though that's not always true. But we'll say the formats they have can test a little bit faster sometimes. And they're generally less expensive than the large multiplex panels. So they're often a nice cost-effective compromise from testing every virus and pathogen under the sun. They're going to test these critical respiratory viruses that are either of actionable medical, we could actually treat them like COVID-19 and flu with the correct indications, or triage, very young people or very old people with RSV, having that sort of severity indication for testing. And these are less restricted to those reimbursement restrictions as well. So they become a very nice and commonly implemented testing modality, both in clinical laboratories and large hospital systems, as well as outpatient settings and urgent care settings. One other format is just testing RSV alone as a single analyte. And there are both nucleic acid amplification options, but also antigen testing options, as I had mentioned. There's no multiplex lateral flow assay that includes RSV, to my knowledge, at this time. And even if it was, there are going to be very few options. So these single analyte options, both nucleic acid amplification testing and antigen testing, are just less commercially available than these multiplex tests. But to their advantage, they are lower cost and they're potentially easier to implement in a point of care setting. So for someone who may be doing antigen tests, like Dr. Davidoff, you mentioned you did a COVID and a flu antigen test, those are going to be quite fast and easy to do in an urgent care clinic. But if you're in a hospital system where you are taking a test and then sending it off to a clinical lab, these may be much less efficient than testing a panel of tests versus doing a bunch of single analyte tests. So if you're testing for COVID alone, flu alone, and RSV alone, you can imagine the inefficiencies in that system that may not be effective. And one thing to talk specifically about antigen testing is that it is lower sensitivity in adolescents and adults. So it is not necessarily the gold standard test for testing in these patients, but you're really going to have to analyze your patient population and see if this works for you. But what that means is in older adults, if you only have an antigen test available, a negative test may be a false negative. It's not always a false negative, but it has a higher chance of being a false negative compared to a nucleic acid amplification test. So what are some of the benefits of point of care testing? Being able to offer it sort of within the clinic, either being a nucleic acid amplification test or a antigen test, are rapid turnaround time. Everyone wants to be able to provide the best care possible, and oftentimes that's getting the answer the quickest to make an actionable result. So if there is an actionable result, rapid turnaround time matters. Optimize healthcare resource utilization for those same reasons. Potential for decreased antibiotic use and/or decreased duration of treatment, as Dr. Marquez discussed. Increased targeted antiviral treatment. So even though there's no antiviral treatment for RSV, there are, for the other pathogens that you may be testing, antiviral treatment that you can get on board sooner. Reduced transmission and infection control, which we have talked about quite a bit. Enhanced access and convenience. This is probably the biggest thing that people would anchor on, is that just having control of doing testing at the point of care setting is just so much easier than having to rely on a clinical lab if you don't have to. If you have the ability to do it and it's really efficient within the clinic, you are going to have a lot more control over it. And then surveillance and outbreak monitoring. These are really important at the population level and at the public health level. They inform things as emerging pathogens are evolving, or give you a better characteristic of what's going on in your population so you can make population-based health decisions. All right, so for Dr. Davidoff, in urgent care, what role do rapid antigen tests currently play compared with PCR? And how do you balance considerations of speed, accuracy, and cost when selecting a testing method?
Thank you. Yeah, this is kind of a loaded question. I mean, I think rapid antigen tests are widely available. They are inexpensive. So if you're on a case-based reimbursement type system, it's not going to cost you a ton of money out of the amount that you're getting paid per patient. They're really easy to do. We're all ridiculously familiar with how to do these, and we're very efficient at doing these because we've been doing it since the beginning of the COVID pandemic. So, and I think they're the most widely used in urgent care currently. The problem is at this point is they're getting, I don't know, it seems like they're getting less accurate as far as that's concerned. We all know that if it's positive, that's more than likely a true positive because the specificity is so high. But the sensitivity seems to be getting significantly lower now. So, when I have somebody that has all the right symptoms, I probably tell them, even if their test is negative, that you're probably positive. So if I have a negative test, I can tell them, well, I'm about 70 to 85% sure that you don't have COVID or influenza or RSV. And, that's okay for those people that are not at high risk, but that's not okay in patients that are high risk. So it would be nice to have a more wider availability to PCR and to have those higher sensitivity and that better answer from that better technology than what the rapid antigen tests are currently. As PCR or the NAATs are becoming more widely available, more accessible at the point of care, and less expensive at the point of care, I think we're going to see that playing more of a role than the rapid antigen tests. But for now, like I said, what we have that's more widespread is definitely those rapid antigen tests, and that we're seeing that more commonly in the community. So, absolutely, as far as balancing speed, accuracy, and cost, I think speed and cost is very, very important in the urgent care setting. We look to get the patients in and out the door in an hour. So having a test that's very quick is very important to us. And again, we're also looking at the cost because if it's coming out of what we're being reimbursed, then we want it to be as inexpensive as possible. But, we don't want all of that out of out of the accuracy. So all of those things are very important. But I think, a lot of times in urgent care, the speed and the cost tends to be a little bit more important, which, is I don't want to say it's sad, but sometimes we sacrifice one for the other. And that's, in the future, we will, as PCR technology becomes more inexpensive and more available, I think we're going to see that becoming more popular.
That's a really good perspective on it. And Dr. Marquez, what are the advantages and limitations of single analyte RSV tests versus multiplex panels that also detect influenza and COVID-19? How should clinicians decide which format is most appropriate for their setting?
So, my take on this is that a lot of this depends on what you already have available, but in general, when we're testing for RSV, we're also going to be testing for influenza and COVID-19 in part because this is generally during the respiratory virus season where the influenza and COVID are on the differential with RSV. So you want to test for all three during that time. So multiplex, I think, is ideal that they're all three there. But if you're in a system where you already have a system for influenza and COVID-19 testing, and you want to be able, and you should have a test for RSV, and so you can use a single analyte test to add it on. I think this question about adding on an RSV antigen test in one setting, there are some advantages. Of course, the speed is helpful. It's always nice to be able to get the diagnosis right then and there and discuss it with the patient immediately, although, of course, really trying to incorporate the test characteristics and how you're interpreting them, especially with the lower sensitivity with adults and the antigen test and compared to the PCR testing. So I think it's helpful. The single analyte is helpful as an add-on test during the respiratory virus season. And that's mostly how I'm thinking about. And or if you're interested in adding a more rapid RSV testing, for example, in settings that need to send out for a multiplex panel, there may be a role for the antigen testing, especially in children. So really thinking about speed, patient population, and what existing lab tools you have at your disposal.
That's also really interesting as well. And I know in our practice together, when we were at the same hospital, just sometimes there'll be cases where you did one initial test and then we'll get that call to add on to the lab for it. And so being able to run that single analyte test is important. And one thing to point out too, because there is a little bit of a nuance, is these multiplex panels, you can actually turn off some of the targets. So we actually may be running a multiplex panel, but then turning off some of the targets just to test RSV alone. And I know that there are emerging platforms that are coming out, which actually run all the analytes, but hide the ones that are not ordered, but you can actually unhide them without running a second test. So diagnostic companies and laboratories are becoming more familiar with the need for single analyte testing, but having it in a format that is sort of in line with multiplex as a screen, but then you may have to do additional testing or modulate what analytes you actually want to see. So it's good that these are all, this sort of discussion goes along with the way the market and the available tests are.
That's interesting that you should say that because as I alluded to earlier, most urgent cares will have a standing order to do at least the COVID and the influenza on patients that have appropriate symptoms. So we don't want to just add RSV to all of those patients. So that might be something that would probably be something that the clinician would order after they've seen the patient and know that the COVID and the flu are negative, or know that that patient is someone at high risk that we need to know if they have RSV. So that would end up being an add-on later as a second test or a third test in that case. So, the question would be would that be something that you could then add to the test that was already done, or is that something that you would need to add as a single test later? So just food for thought.
Yeah, and the other bottleneck there to think about, and why you should have a wide multidisciplinary discussion on this, including the clinical laboratory, is that it's not just what's available on the test, it's actually how the clinician can communicate that to the clinical lab to know that. And so our ordering systems and our informatics systems within our healthcare systems are really important to bridge that gap. They are often separate from the tests themselves. So being able to have an efficient way to say, oh yeah, I do want to add on this test afterwards, and communicate that effectively to do it, and then hopefully not have to run a second test later down the line. All right. Next, we're going to talk about logistical considerations about implementing point of care testing into ambulatory care. The key drivers for decision-making to uptake point of care testing for respiratory infections are multifactorial. But as we just alluded to, having multidisciplinary discussions or stakeholders is very important. Those stakeholders should really understand the clinical relevance of that testing from their population and all bring that to the table. And then governance, often coming from quality assurance and sort of the competency of testing. The testing that you're providing is adequate for that population. And all of those should go into the decision about whether this can be offered at point of care or not, or if it has to be a send out or into a more centralized lab for testing. Workflow considerations for RSV testing, often the things that I'm talking to clinicians about deciding what workflows we can have are inpatient versus outpatient testing. This is really important for triaging, how fast we have to provide the test and at what level we have to provide the test, i.e. what breadth of multiplex testing do we have to provide? A larger panel, or would a smaller panel suffice? So part of this is education and diagnostic stewardship to provide cost-effective implementation. So we may have both test options, but we have to make sure we have a dialogue with our clinicians about, in this setting, inpatient setting, we may order a larger panel, and in outpatient setting, we may order a smaller panel, and that has both clinical and reimbursement repercussions. Testing based on risk for severe disease. So as we mentioned, children and less than 5 and adults greater than 65 have the highest risk, and testing in those populations may be the most important. So we want to make sure that you have that test available and providers know about it for those populations. But in adults who may be lower risk, but have other underlying conditions like lung diseases, COPD, or maybe immunocompromised, we may want to make those tests available. So understanding that not every adult has the same risk as, has the same lower risk as other healthy adults, that understanding underlying conditions can make a difference and may change the decision to test. One thing we haven't talked about as much is upper respiratory tract versus lower respiratory tract. This virus may affect both, your upper airways and your lower airways in your lungs. Oftentimes, sampling an upper respiratory tract, even if there's a lower respiratory tract infection, is sufficient because the virus is continuous throughout those sort of two distinctions of that system. So even if it's a lower respiratory infection, you could still do upper respiratory tract. But let's just say the patient wasn't known to have it, or the upper respiratory tract or the upper respiratory tract test was falsely negative and there was still a high clinical suspicion, so they went a little bit lower, maybe did a bronchoalveolar lavage, you still may want to test that specimen because the virus may be most active in that area. So they may send that to the clinical lab, and a lot of those lower respiratory tract specimens may not be cleared for testing in your lab, and they have to be sent out. So knowing what specimens your laboratory will test and sort of like when an upper respiratory tract infection may be falsely negative, especially if it's moved down into the lower respiratory tract, will be important for knowing the clinical indication for testing, and just knowing that these are considered different anatomical sites and have their own limitations for testing. So we've talked a lot about the different modalities of testing and the different indications for testing and different workflows. So this is sort of a summary on how to think about these in terms of turnaround time, and really distills what you may want to bring for your patients. So for point of care testing, we're really thinking about this in an optimal setting of being 30 minutes to an hour. Sometimes it can be more, so we put an hour plus, but point of care testing will be important if you are maybe in a outpatient clinical setting where you really want to capture the diagnosis while the patient is still in your clinic. So if you're saying all the patients I'm seeing are only in an ambulatory clinic, I only are seeing patients in this setting, you may be thinking more about bringing in point of care testing. However, if you're in a larger medical system that has a centralized laboratory and you may not have to capture that patient right at that time that they're presenting, you can follow up with them later, either through the electronic medical record, telehealth, or whatnot. It may be more effective to do centralized testing. You can swab the patient, have them go on their way, isolate supportive care, and then follow up with them later. The testing may be a little bit slower, but is often quite fast if it's done on site in a centralized lab. Not everyone may have that capacity, but still understand that their patient population doesn't need it as acutely within 30 minutes to an hour, and they may send out to a reference laboratory setting. And that can often take 1 to 2 days plus. I say 2 days plus because every reference laboratory is different, but this is something where if it makes sense, it may be the most cost beneficial to do this, especially if you're in a resource limited setting where you're like, I really just do not have laboratory capacity. Sending out and following up with patients later could make the most sense. All right. Dr. Davidoff, what are the most significant challenges to integrating RSV point of care testing into ambulatory care workflows? And how might these be addressed collaboratively across clinical and laboratory teams?
Well, I think one of the challenges is, change is always hard. So getting people to know when they should be testing for RSV and when they should not be testing for RSV is one of the education pieces that needs to be done when you decide that you're going to add RSV to your arsenal. The other step is training staff. Obviously, they have to be trained to learn how to operate whatever platform it is that you're going to be using to do your testing, whether that's antigen testing or PCR testing. If it's similar to previous tests that you've done, like for instance, antigen testing, and you're already doing antigen testing for other things, likely that workflow is going to be exactly the same and it's not going to be that big of a challenge. But if you're now adding PCR testing for RSV when you were previously doing antigen testing, and this is something new to your staff, obviously there's going to be a learning curve to teach people how to do that. I'm assuming that pretty much everybody has a way to initiate new procedures and protocols into their clinic, but obviously a learning curve on how that's going to work. I think probably the biggest challenge would probably be educating clinicians on when the RSV testing would be indicated and when it's not indicated. And this is something that has to come from the top down as far as education. So the clinical leaders, really have to provide that education. Also, as far as laboratory, if it's something that's going to be a send out, that's also, you have to know which lab you're going to need to send it to, and how that process is going to occur. But, like I said earlier, we're used to change in urgent care, so that's something we could certainly learn rather quickly. But, I think this is something that's really important to address. I don't want to say RSV is up and coming because it's been around for a long time, but it's now more recognized and the impact of it is becoming more obvious to us. So it is something that we're going to need to embrace, if not for this RSV season, certainly next RSV season.
Great. So this is such a fantastic roundtable, and I had a lot of fun discussing RSV testing with you, and I hope our listeners also enjoyed it and learned a lot. I'm going to just summarize some of the key take-home points to close the session. So first, RSV is a major but under-recognized cause of acute respiratory infection across the lifespan from infancy, where we see a big impact. And then I think we've highlighted really the impact on older adults as well. Second, accurate diagnosis has benefits both for the patient and public health. Third, molecular testing is the gold standard for RSV testing for adults. And fourth, implementation barriers may exist. I think our last session just really, nicely discussed many points there. But education, especially when you're introducing a new test, is key, both for your providers and then also for the patients. So with that, we'll close. Thank you so much for joining us.
Thank you to our faculty, and many thanks to you, our listeners, for joining us. To view the full program on the role of RSV diagnostic testing and to download the accompanying slides, click the link in the show notes. And to get access to all of our new podcasts, subscribe to the DSERA Infectious Disease podcast on your favorite player. Thank you, and we'll see you on the next podcast soon.